Welcome to Learn from the Case. Hello, how are you? I opened this channel to present some cases. I work within neurology and internal medicine, and I want to share a little of what I have and am learning. I want to comment that I work in different hospitals in different countries. I also train in different countries, so that's taken, which initially include the spinocerebellar ataxias and Huntington disease. No mutation was identified with this test, leading to subsequent testing of the ATN1 gene, atrophin 1 protein. The patient began to show myoclonic jerks. A recently graduated physician who was obsessed with Huntington's and also personally knew a person with that disease was convinced that it was a Huntington. He was doing a neurology rotation and was always accompanying a neurology resident, and the latter made the diagnosis Huntington and he presented the case to me. We ordered genetic, geomatics, and other analyses, and it turned out to be DRPLA. It is actually quite common to these two conditions to be mixed, even among specialists. There are no clinical trials assessing the efficacy of different anti-epileptic medications in treating seizures in DRPLA, just and specifically in patients with DRPLA. Patients with epilepsy are usually treated with a standard anti-epileptic treatment, but phenytoin should be avoided because it may worsen ataxia. Phenytoin can damage cerebellar Purkinje cells. Clinical signs of ataxia can persist without radiological evidence of cerebral atrophy, and cerebral atrophy can be seen without clinical evidence of cerebral dysfunction. Cerebral atrophy might be seen in acute phenytoin poisoning or in patients that was taking phenytoin during a long time. Dentatorubral-pallidoluysian atrophy is a rare autosomal dominant neurodegenerative disorder. The average age of onset for DRPLA is around 30 years old, but this condition can appear anytime between infancy and mid-adulthood, affecting males and females equally. It is clinically characterized by various combinations of cerebellar ataxia, choroiditis, myoclonus, epilepsy, dementia, and psychiatric symptoms. The most striking clinical feature of DRPLA are the considerable heterogeneity in clinical presentation, depending on the age of onset, and the prominent genetic anticipation. DRPLA is caused by unstable expansion of CAG repeats, cytosine adenine guanine repeats, coding for polyglutamine stretches, located in exon 5 of the DRPLA gene. DRPLA is characterized by prominent anticipation with paternal transmission resulting in more prominent anticipation than those maternal transmissions, which is now understood based on the intergenerational stability of the CAG repeats. DRPLA protein, also called atrophin 1, is localized in the nucleus and functions as a transcription co-regulator. Recent immunohistochemical studies and autopsied tissues of patients with DRPLA have demonstrated that diffuse accumulation of mutant DRPLA protein, or atrophin-1, in the neural nuclei, rather than the formation of neuronal intranuclear inclusions, is the predominant pathologic condition and involves a wide range of central nervous system regions, far beyond the systems previously reported to be affected. Thus, age-dependent and CAG repeats dependent intranuclear accumulation of mutant DRPLA leading to nuclear dysfunctions are suggested to be the essential pathophysiologic mechanism in DRPLA. The degenerative pathological changes seen in DRPLA mainly affect the dentate nucleus with its projection to the red nucleus, and the external pallidum with its projection to the subthalamic nucleus. Usually, the dentatorubral system is more severely affected. Atrophy may also be present in other basal ganglia nuclei, the thalamus and the inferior leaves. In several cases, degeneration of posterior columns and spinocerebellar tract has been described. Involvement of the pontine tegmentum has also been found, and this appeared to correlate with oculomotor abnormalities. Ones thought to be found mainly in the Japanese population. This autosomal dominant disorder is now known to be more widespread. The discovery of expanded cytosine adenine guanine repeats in the DRPLA or ATN1 on chromosome 12p that codes for the atrophin-1 protein, which is phosphoryled by C-Jan Ng-terminal kinase. The hallmark of brain histopathology is atrophy of dentatorubral and pallidoluysian systems, as the name of the disorder implies, but occasional degenerative lesions are found in the cerebral white matter and the putamen, among other structures that are being investigated. The neuropathological spectrum in Caucasian patients with DRPLA is essentially identical to those described in Japanese patients with DRPLA. Expanded polyglutamine stretches are diffusely accumulated in nucleoplasm of the wide variety of neurons in the cerebral nervous systems. Like Huntington's disease and Machado-Joseph disease, the inclusions in DRPLA are immunopositive for several transcription factors such as theta binding protein, TBP-associated factor, SP1, CAMP, responsive element binding protein, and CREB binding protein, suggesting that neuronal degeneration might result from nuclear depletion and transcription factors containing the glutamine-rich domain. The mutation is an expansion of a polyglutamine-coding CAG repeat in the DRPLA gene on chromosome 12p. Early onset of the disease includes ataxia, myoclonus epilepsy, and progression to dementia, while adult onset cases show cerebellar ataxia and psychiatric symptoms, which might accompany seizures and choreoathetotic abnormal movements, resembling a Huntington's-like phenotype. Families with DRPLA show continuous anticipations, and the age of onset and severity correlates with the length of the CAG expansion. The mutation in the DRPLA gene has also been found in the Howe River syndrome, which was somewhat different clinical characteristic from DRPLA, and for some writers are different conditions or disease. Disease onset in DRPLA varies between infancy and late adulthood, with features of anticipations. On average, the onset of clinical features begins at approximately the age of 30 years. The clinical picture of DRPLA is characterized by a wide range of clinical manifestations, the precise nature of which depends on age of onset and repeat length. The most constant clinical findings in DRPLA are cerebellar ataxia, dysarthria, and progressive dementia. These features are present in almost all patients, irrespective of age of onset and repeat length. Patients with disease onset before the age of 20 years and large expansions show the clinical syndrome of progressive myoclonus epilepsy. Some of them have opsoclonus. In patients with later disease onset and shorter expansions, myoclonus and seizure are less prominent. Instead, many of these patients have involuntary, choreic, or dystonic movements and psychiatric abnormalities, including personality changes, hallucinations, and delusional ideas. Various oculomotor disturbances have been described, including gaze-evoked nystagmus, broken up smooth pursuit, square wave shakes, and vertical gaze palsy. Dentatorubral-pallidoluysian atrophy, like Huntington's disease and several spinocerebellar ataxias, is a member of a group of genetic diseases in which the mutation is an expansion of a sequence of three nucleotide base pairs, cytosine adenosine guanine, CAG, 3 nucleotide repeat, because CAG codes for the amino acid glutamine. These conditions are also known as polyglutamine expansion diseases. DRPLA manifests as various combinations of cerebellar ataxia, choreoathetosis, myoclonus, epilepsy, dementia, and psychiatric symptoms. The clinical presentation can resemble progressive myoclonic epilepsy, especially if onset is before age 20 years. The most common syndrome after age 20 is ataxia, choreoathetosis, and dementia. Brain MRI scans show characteristic atrophy of the pontine tegmentum and cerebellum. The DRPLA is autosomal dominant with high penetrance. The DRPLA gene is on chromosome 12p and codes for a protein of unknown function, which appears to localize in the nucleus. The DRPLA is characterized by prominent anticipation. The offspring inheriting the mutation began to experience symptoms at a younger age than their parents. Anticipation is more marked when the mutation is inherited from the father rather than the mother. As in several other diseases caused with a CHG repeat expansion, the length of the expansion, the CHG repeat load, relates to the phenotype. The longer the expansion, the earlier the age at onset of symptoms. In addition, age at the time of imaging and size of CHG repeats seem to independently influence the degree of cerebellar and pontine atrophy. It is likely that mutant DRPLA proteins with expanding polyglutamine repeats are toxic to neurons. Autopsy studies showed accumulation of mutant DRPLA protein in neuronal nuclei. Mutant DRPLA may interact with nuclear protein, interfering with transcription and leading to neuronal death. Myoclonus likely results from degeneration of specific brain structures, but the widespread nature of this degeneration precludes confident identification of the pathogenesis of myoclonus in this condition. The diagnosis of the DRPLA is made by demonstration of an expanded CHG repeat at the DRPLA locus. The differential diagnosis of juvenile onset cases presenting with progressive myoclonus epilepsy includes Aufferich's lumbar disease, mitochondrial encephalomyopathy with ragged red fiber, neuronal ceroid lipofuscinosis, Lefora body disease, and sialidosis. Adult onset cases of the DRPLA might be confused with Huntington's disease. Clinically, the presence of ataxia and seizures makes Huntington's disease unlikely and points to a diagnosis of DRPLA. DRPLA is distinct from spinocerebellar ataxia in having the clinical features of dementia, a syndrome of ataxia, myoclonus, and rapid cognitive decline similar to that in DRPLA may occur in Creutzfeldt-Jakob disease. Compared to DRPLA, however, the progression is usually faster in Creutzfeldt-Jakob disease. In exceptional cases, DRPLA might be mistaken for schizophrenia. With the EEG, you may see that electroencephalographic background activity is slowed in approximately 80% of DRPLA patients. More than half have epileptiform EEG patterns, and in approximately 1/3, the EEG reveals photosensitivity. MRI of DRPLA patients show atrophy of the superior cerebellar peduncles. In addition, T2 show high intensity signals in the pallidum. There is no specific treatment for DRPLA. DRPLA patient with epilepsy requires standard antiepileptic treatment. As I said before, phenytoin should be avoided because it might worsen ataxia. DRPLA is a progressive disorder. You might see that in the clinic and the MRI. In MRI T2, you see symmetrical diffuse white matter hyperintensities. That's in the cerebrum. Deep brain structures, namely the thalamus and globus pallidus, although the midbrain and pons may be involved in elderly patients. Spreading of white matter changes through the corona radiata and centrum semiovale has been reported at follow-up. Additionally, atrophy of the cerebellum and pontine tegmentum are typical, with the extent of atrophy correlating with the extent of CAG expansion. Generalized atrophy is reported in most patients. There are several ailments that can resemble DRPLA, as I said before. We spoke about spinocerebellar ataxia, Huntington's disease, Creutzfeldt-Jakob disease, but also Sydenham's chorea, SLE, and much other. It depends, of course, on the symptoms and clinical manifestations. I would like to mention some treatment for myoclonus, depending on the underlying cause. This is not specific for DRPLA. So, tips of treatment for patients with myoclonus: levetiracetam, preferred in cortical myoclonus rather than subcortical or spinal, 1,000 to 3,000 milligrams a day, divided twice a day. Dose up to 4,000 milligrams a day has been used. Then we have clonazepam, can be used in cortical, subcortical, and spinal myoclonus, starting dose 0.5 to 1 milligram a day. Typical dose 3 milligrams a day or more, sometimes up to 15 milligrams a day. It is not first-line treatment in view of habit-forming risk. This, of course, has more or less relevance depending on the age of the patient and the expectation, the diagnosis, and everything. Furthermore, I do not know to what extent the tolerance of this effect has been studied. It is known that other effects of benzodiazepines are softened or disappear. The patient develops tolerance with time. So then the next one is valproic acid, typical dose 1,000 to 1,500 milligrams a day. Then we have zonisamide on primodone, used less commonly just when valproic acid failed. Dosing for zonisamide is 100 to 200 milligrams a day, and for primodone 500 to 750 milligrams a day, but usually poorly tolerated at such high doses. Then we have botulinum toxin injection, especially against hemifacial spasm. And the last one I will mention here is deep brain stimulation. This improves both dystonia and myoclonus. This is especially important in, for example, myoclonus dystonia syndrome. I hope this video has caught your attention. This presentation is entertainment for students and health professionals who want to listen to studies, discussions, or clinical cases. It is not intent in any way to replace the learning provided by reading medical literature or the experience provided by clinical practice.